Okay, and so I'm going to introduce Amy before I turn it over. So Amy Tellinghusen is a clinical associate professor in the Division of Hematology Oncology and is a member of the Leukemia and Lymphoma team here at Seattle Children's. She also serves as the medical director of the Center for Cancer and Blood Disorders, including both the inpatient unit and outpatient clinic. Amy joined Seattle Children's in the fall of 2019 after practicing general pediatric oncology for 8 years in Austin, Texas, at Dell Children's Medical Center. She was born and raised in Texas, and the Pacific Northwest has become a welcome change in spite of its general lack of Tex-Mex food. Amy, I feel you on that. She loves, loves, loves the Pacific Northwest summers and spends as much time as possible exploring the area with her husband and 2 boys. With that, I'm going to go ahead and hand it over to Amy for our talk. Thanks, Amy.
Thanks, Erin. Hi, everybody. Thanks so much for having me today. Such an honor to be able to come and share your lunch with you today. I want to just recognize up front that many of you probably don't see a whole lot of childhood cancer in your practice, leukemia specifically, and that's a good thing. But at the same time, if you do come across it, it can, I imagine, be pretty unfamiliar and probably a little bit intimidating if something that is very frightening to families and something that you don't do very often. So my goal today is just to help familiarize you all a little bit more with some of the steps that we take and some of the things to be aware of when a patient is newly presenting, and also what the families may be going through in the first few steps of their journey, so you can help guide them about what may be coming for them. So with that, there we go. Let's talk about our objectives for today. So our objectives are really first to review the types of childhood leukemia that we see and just general epidemiology, to recognize the common clinical presentations of childhood leukemia, and specifically to identify what those red flag features are that should really stand out in your brain, to outline the evaluation that we use to diagnose leukemia, and to be particularly aware of the oncologic emergencies that can come up in a new patient with leukemia, because that's something that you may face before they are connected to the subspecialist, and to just describe some of the general treatment strategies and late effects caused by treatment so that you can kind of help your families and patients prepare for what's to come. I'm not sure why. Oh, there we go. So it's good that childhood cancer is rare. It is only about 14,000 cases in the United States annually. Here in the Seattle area, we see about 300 cases at Seattle Children's per year, and about a third, a little bit more than a third of those are hematologic malignancies. So about 100 or so of those are leukemias and lymphomas. The causes of them are not clear. Why this happens is a common question that families ask us. And what we tell them is that we don't know about any specific links to environmental factors, but we do think that there's probably a multifactorial risk of sometimes genetic influences, immunologic influences, and sometimes infectious factors. But in general, we say, there's nothing that you could have done to prevented this in your child, and we don't know why this happened. So this is probably pretty basic, and I'm sure you all know this, but what is leukemia is a common question we get from families when they're coming here for the first time. And the very basic answer is that leukemia is a cancer that starts in blood-forming tissues, specifically in the bone marrow. And I found this little paragraph helpful. This was published on the Cure Search website, which is an organization that is run by the Childhood Oncology Research Organization. And I think it just sort of outlines the way I usually describe what leukemia is to a family. Basically, that this is something that starts in the place where your body makes blood, and it happens when a young white blood cell is trying to make a new white blood cell, and a mistake is made or a mutation happens that allows that white blood cell to start growing and dividing uncontrollably. And when that happens, the marrow spaces start to fill up with all those bad white blood cells, and it makes it difficult for them to produce all the healthy parts of the blood, including our red blood cells, our platelets, and the healthy white blood cells that protect us from infection. So I think it's a good resource for families to just kind of get a general understanding. So what are the kinds of leukemias that we see in kids? They're different than what we see in adults in general, but there are kind of two big categories. The first is acute leukemias, and this really is a clonal expansion of immature white blood cell precursors. And then the alternative is chronic leukemias, which is a clonal expansion of the mature components of the bone marrow elements. And by far, the most common thing that we see in children are acute leukemias. As you're probably familiar with, the most common acute leukemia that we see is acute lymphoblastic leukemia, which is about 80% of the leukemias that we see. And acute myeloid leukemia, or AML, is the second most common leukemia that we see, and that's about 15% of what we see. The rest is composed of chronic leukemias, which are fairly rare. Chronic myelogenous leukemia is similar to what you see in the adult population, but really comprises less than 5% of the leukemias that we see. And we really almost never see CLL in the pediatric population. So not to give you PTSD from your pathology experiences in medical school, but this is just an illustration to show you sort of the cell lines where the leukemias can occur. And at the very tip top, that is a multi-potential hematopoietic stem cell, or a baby stem blood cell that can become any kind of blood cell in its future. And it can branch off and either become a lymphoid progenitor or a myeloid progenitor. And then you can see down here, as the myeloid progenitors continue to differentiate, you can see the different types of cells that can become malignant. And the most common that we see is monocytic or a myelomonocytic myeloid leukemia on the AML side. And again, this is about 15% of childhood leukemias. And then on the lymphoid side, again, the most common kind of leukemia that we see is ALL, or lymphoblastic leukemia. And there are two sort of flavors of lymphoblastic leukemia that we can see, and that has to do with whether or not it's the B lymphocyte or the T lymphocyte involved. And the most common thing that we see is B cell ALL, and it's about 80% of the ALLs that we see, and the other 20% are T cell ALL from that other lineage. So, we said that genetic factors sometimes can play a role in who may be at risk for developing leukemia. And specifically, the best example of that is patients that have trisomy 21. They are at a really increased risk of developing leukemia during their lifetime. We all know that leukemia is rare in the general population. So it is 150 times higher in patients with trisomy 21 for them to develop AML in their lifetime, whereas for ALL, it's about 15 to 20 times higher. So it's still relatively rare in the trisomy 21 population. It's about 1% of those patients. However, that's a lot higher than the percentage in the general population. So there is a phenomenon called transient abnormal myelopoiesis, we call it TAM, that can occur in newborns with trisomy 21. It occurs in about 10% of them, and it's a phenomenon where in the newborn period, they can develop leukocytosis. Sometimes they can be asymptomatic, and they can have leukocytosis found incidentally, and they will often have abnormal white blood cells in their peripheral blood called blasts that are consistent with leukemia cells. What's really fascinating about this is that most of the time this just spontaneously gets better and goes away. By about 3 months of age, babies clear, their complete blood counts normalize, and their blasts go away. Some of these babies actually, though, can have life-threatening complications from this and can be very, very sick in the NICU And some of that is because as this proliferation of white blood cells occurs, it can cause pretty massive organomegaly of the liver and spleen, causing respiratory insufficiency and all kinds of other issues. For those patients that are at risk for that, we do use some low-dose chemotherapy for them to try to help prevent these life-threatening complications. But usually that's all that they require, and they can get better. But what's important about this population is about 10 to 30% of them will develop real AML before they're 4 years of age. So for this population especially, we encourage them to be plugged into a pediatric oncology team, and we will help with the surveillance of this for the first 4 years of their life to make sure we don't see anything that's concerning. We also encourage that all newborns with a diagnosis of trisomy 21 have a complete blood count in the first few days of life so that we can identify this. So what is the clinical presentation and what kinds of things might you be seeing on the front lines in your office? And so most of the symptoms are side effects of having the bone marrow infiltrated and not producing the normal numbers of healthy blood cells. And specifically, patients can have symptoms of anemia, which I'm sure you're familiar with, include pallor, tachycardia, dizziness, headaches. Sometimes they can have a murmur on exam, and just generally feeling fatigue and malaise. Having low platelets, thrombocytopenia, many of these patients will have mucosal bleeding, gingival bleeding, nosebleeds, petechiae. You know, kids get bruises all the time, but sometimes they'll present with just really abnormal bruising in unusual places, etc. And then neutropenia. Neutropenia in and of itself really doesn't cause symptoms, but sometimes patients will have unusual infections or unexpectedly severe infections or fevers. And then bone pain, and this is one that I want to highlight because kids have pain all the time, but bone pain specifically is something of a red flag. So if you have a patient with any of these other symptoms, or maybe even not, who is limping or just refusing to walk, especially in the toddler kind of preschool age where their ability to communicate what they're feeling is not great. Some of them are just not wanting to bear weight. Back pain is often a complaint, and just in these little non-walkers, sometimes they're just super fussy because they don't feel good and they hurt. So what things can be red flags? Because in leukemia, right, fevers and fatigue, you know, a lot of these things are just really vague complaints, and they're things that you see in common viral infections. And how do you differentiate between just a normal virus that's running its course and something to be worried about? So I think, you know, in our minds, the persistence of fevers that aren't explained, so fevers that are not associated with cold-like symptoms that are continuing beyond what you would expect, you know, more than 5 or 6 days, or fevers that are intermittent, that are ongoing. So patients may have fever for 2 or 3 days at a time, then it resolves, and it comes back and goes away, and comes back. So kind of fevers of unknown origins that are persisting. We talked about the bone pain specifically. Sometimes bone pain is the only symptom, and people are worked up with x-rays, and occasionally we'll get a call that they've been working up bone pain or knee pain, for example, with an MRI, and oh my gosh, the MRI has very abnormal bone marrow signal. That's actually really concerning to us, and I would say more often than not, when the MRI shows concerning marrow infiltration, we actually will find leukemia. So if you hear that or see that on a report, please let us know. Presence of hepatosplenomegaly on your exam, any bleeding or bruising that seems outside of normal, and then lymphadenopathy. So, you know, viral infections can often come with lymphadenopathy, but lymphadenopathy that is sort of persisting or bigger than you would expect, or not going back down is something to think about. And this may seem a little random, but orthopnea or shortness of breath when laying flat is another red flag that you might hear people mention. So leukemia can also present itself outside of the bone marrow, so you can have proliferation of these white blood cells in other places. And some of those include, we just talked about lymphadenopathy in the liver and spleen, but you can also have deposits of these white blood cells under the skin subcutaneously, and that's called leukemia cutis. You can see this little baby here that has these little purple spots. These are probably palpable. Most of the time, they're these little subcutaneous nodules that you can feel, and often will have this purple hue like this. Mediastinal mass is something that we can see. Testicular enlargement or asymmetry is another place where you can see this. Central nervous system involvement, so some patients can present with cranial nerve palsies, which is a concerning sign for extramedullary CNS involvement. Gingival hyperplasia, you can see this picture right here of really thickening of the gums. If you see this in somebody with pancytopenia, this is concerning. And then sometimes we can see basically masses or tumors, and when they're biopsied, they are leukemia cells, and this can happen in the bone or the soft tissue or really anywhere. So this is just an example of an algorithm we have on our Seattle Children's website that can help with the workup of lymphadenopathy. You know, obviously with lymphadenopathy, we think not just about leukemia, but also about lymphoma. But this is just a resource to help you all kind of guide your workup and think about what those red flags are, and sort of when to refer to the specialist to think about those. So just wanted you all to be aware that that resource exists. And then also, starting, I think it's next week, we will also have an e-consult available for you all where you'll be able to submit some kind of basic information about lymphadenopathy, sort of the size, how long they've been there, any constitutional symptoms, and our oncology team will review these and kind of give you some general recommendations about if we think the patient needs to be seen in our clinic or kind of what some next steps might be. So the initial workup. So I think one question that folks often ask is, when do I need to do labs, right? You've got a patient with some vague constitutional symptoms that probably is viral, but may not be. And really the answer is anytime you see one of those red flag symptoms or red flag exam findings, is a time where you should be thinking about doing some labs. And then also, if even without any of those red flags, if you have a patient with some of these vague symptoms and it's just not getting better in the time frame that you would expect, it's always reasonable to do some labs. And then another question we often get is, when does my patient need to go to the emergency room? Is this something that we can manage in the clinic and get them into your clinic, or is this something they need to go to the emergency room for? So if you suspect a leukemia, the things that really mean the patient needs to go to the emergency room are any concern for a mediastinal mass. So if the patient has any orthopnea or respiratory distress, of course, those patients need to go to the emergency department. If you get a CBC result back and they call you and say there are peripheral blasts, even if that patient is well appearing, we'll oftentimes ask you to have the patients going to the emergency room, just because it will allow us to expedite that evaluation and workup. And a lot of that stuff will need to happen in the hospital anyway. If you have pancytopenia without clear blasts or leukemia cells on the differential, that's where I think we can have a conversation about patients that are clinically quite well. Perhaps they can come to our clinic and be seen on a slightly less urgent basis. Of course, still like either same day or next day, but maybe avoid that emergency room experience if possible. CBC findings that require transfusion is another reason to go to the emergency department. And then I want to highlight fevers. So anytime you have fevers and you get a CBC back and you find that they're cytopenic, particularly neutropenic, that would be a reason to send the patient to the emergency department. And if you're not sure, call us and we can talk about whether or not we think the patient needs to come into the ED or through the clinic. We can help triage. So what is the workup that we recommend? And I think obviously the first thing that we would recommend is a complete blood count with a differential, and then also chemistry. So we will be looking for any signs of high cell turnover, and that will include looking at electrolytes, including potassium and phosphorus. Creatinine will often ask for a uric acid and an LDH, which can help kind of give us some clues. We'll ask for coags to think about bleeding risk. And then if the patient is having fevers, we'll also ask for blood cultures. Many times we'll ask for a chest x-ray also, and that is because we'll be looking for any signs of a mediastinal mass. I know that you wouldn't necessarily be doing this in your office, but if the patient is in the emergency room outside, we'll oftentimes ask them to start some IV fluids for us and possibly start some other medications such as either allopurinol or antibiotics. And transfusions sometimes are started at outside emergency rooms and sometimes started when they reach us. So what happens when they get to us? We continue all of those things that were started before they get to us. And then, one of the things that we do first to try to get a diagnosis is we send the blood for something called flow cytometry, which is a test that can be run on the peripheral blood if there are blasts identified on the differential. This test can tell us if those cells on the manual differential are abnormal and leukemia cells or not. Sometimes we don't see those cells in the peripheral blood, and that test isn't helpful. We'll often do echocardiograms and EKGs for patients that we're fairly certain have leukemia, because that's something that needs to be done before they start treatment. Sometimes we'll be doing CT scans to identify lymphadenopathy if they're concerning findings, particularly like a mediastinal mass. And then a bone marrow and a lumbar puncture will be performed at the treating institution. And this is just a slide sort of outlining what those procedures look like, so you can help families understand what might be happening in the first few days after they get to our hospital. And so both of these procedures are done under anesthesia, so our patients don't feel any of this and don't remember it when they wake up. But all patients will get a bone marrow aspirate and biopsy in the first few days that we meet them, even if we're able to get the diagnosis from peripheral blood. And that's because there are tests that we can run on the bone marrow that are not possible or not easy to do on the blood. And that specifically includes some of the genetic and molecular testing that we do for our patients. We'll do lumbar puncture, and that is to help us understand the burden of leukemia in the central nervous system. So we'll take spinal fluid and we'll look at the cell count for the number of white blood cells, and we'll also send it to pathology, where they spin the fluid down and spin what's at the bottom onto a slide and look for any abnormal blasts. We also use that opportunity, if we know the patient has leukemia, to start some chemotherapy. So the spinal fluid, the central nervous system, is a protected area of the body where systemic chemotherapy does not go. And so part of patients' treatment will include injection of chemotherapy into that fluid throughout their treatment to try to prevent the leukemia from hiding there and coming back and relapsing there in the future. Sometimes we don't do the lumbar puncture at the very, very first day. If they're diagnosed with AML, we'll sometimes delay that by a week to avoid the risk of bleeding. So what are the oncologic emergencies? What needs to come here soon or come to an emergency room quickly? And these are the four sort of main ones that we see and that we have to act on quickly. And the first one is febrile neutropenia, which the definition of which is fairly self-explanatory, but basically this is fever in the setting of neutropenia. And neutropenia we define as an absolute neutrophil count, or an ANC, of less than 500. And ANC we define as the white blood cell number or count times the number of segmented, or the percentage of segmented neutrophils plus the bands. That gives you your ANC number. A normal ANC for us is over 1,500, and we worry about the risk of unusual and serious infections when it's less than 500. And oftentimes we're asked, well, what do we call a fever? We've defined it as a temperature of over 38.3 times 1, or 2 temperatures over 38 in an hour period without effervescing on its own. So what are the signs of febrile neutropenia? Sometimes people can be completely asymptomatic except for the fever, which is frustrating because it doesn't help us understand where the infection is coming from. But sometimes they can have unusual infections like the eczema gangrenosum with Pseudomonas that you see the picture of here. Sometimes patients can present an overwhelming sepsis that's often the cause of gram-negative organisms, and they can get quite ill quite quickly. And the goal of treatment for febrile neutropenia is really prompt, urgent administration of antibiotics. And the antibiotics that we usually recommend are broad spectrum antibiotics that have pseudomonal coverage. Usually we'll use either ceftazidime or cefepime. And so if we hear about a patient at an outside hospital that we suspect has leukemia or has febrile neutropenia, we'll be recommending these antibiotics, one of these. So tumor lysis syndrome is the next one we'll talk about. And the definition of this is the metabolic abnormalities that result when leukemia cells die and they release their intracellular contents into the circulation. And I think what's important to know is that people can have tumor lysis syndrome before treatment ever starts. I think sometimes people think that can't happen until treatment starts, and then it can happen all of a sudden. But the high cell burden of white cells, these cells are often dying without any sort of chemotherapy. And so you can see these abnormalities in the blood before treatment starts. And the things that we see include hyperkalemia, hyperuricemia, hyperphosphatemia, sometimes with low calcium levels. And the risk of this is that it can cause acute renal failure, partly from uric acid nephropathy, but also you can see calcium crystallizing with phosphate, causing calcium phosphate crystals, also contributing to renal failure. So we manage this with lots of fluids. We always avoid putting any potassium in any fluids that we give to patients with a suspected leukemia because of the risk of tumor lysis and renal failure. We will often give them allopurinol, and in extreme cases, we'll use rasburicase. Sometimes people present in renal failure, or we have difficulties managing the electrolyte imbalances, and we will need to use dialysis to help manage these. And one thing I always mention is that we avoid treating any hypocalcemia unless the patient is symptomatic. And that's because if you give someone calcium and their phosphate's really high, you can actually precipitate some renal failure. Hyperleukocytosis is another common oncologic emergency that we see. And this is defined by the white blood cell count being over 100,000. And when this happens, as you can see in this cartoon here, the white blood cells are increasing in amount, and it really interferes with the blood flow because of all the increased viscosity that has been caused. And there can be life-threatening complications of this, including CNS hemorrhage or clot. They can have pulmonary leukostasis and induce respiratory failure and heart failure. Sometimes patients can present with altered mental status or really bad headaches or vision changes. And so these are definitely some red flag symptoms that we think about when we hear about a patient with a really high white blood cell count. So I found this to be a kind of interesting picture here. So the top one is really what, if you spin blood down and you separate the plasma from the red blood cells, the white blood cells will be this little tiny line right here, the less than 1% in the middle. That's called the Buffy coat, having to dig way back into our med school minds. But if you look here in a patient that has a really high white blood cell count, and they apherese it and take some of it off, look at this, the red cell coat at the bottom is so tiny, and then this cloudy part right here is what should be just 1% or less of the blood. So really quite dramatic when the white blood cell count is high. So how do we treat it? We already talked about hyperhydration. So we'll often give these patients hydration of 1.5 to 2 times maintenance fluids. We actually avoid transfusing them with red blood cells, at least at first, because that can increase the viscosity of the blood and sometimes increase the risk of stroke and other kinds of hyperviscosity concerns. We do want to keep the platelets over 20,000 because of the risk for CNS hemorrhage. And sometimes we will start medications to bring that white count down as quickly as possible, even before we have a diagnosis, if the patient is at risk. And sometimes that is steroids, and sometimes we use a medicine called hydroxyurea. Rarely we can use a process called leukapheresis, where we really just kind of manually take these white blood cells off, which is something we don't use very often and really only done in somebody with really life-threatening side effects already. And it really is only temporary. You won't fix the problem until you start to treat the leukemia. And last but not least, mediastinal mass, we've talked about a couple times already. And the definition of this is a mass of cells that proliferates and grows in the mediastinum, or the front part of the mediastinum. And the risk of this is that it can cause tracheal compression and airway obstruction. And sometimes you'll see signs of superior vena cava syndrome. And this is most common in T-cell malignancies. As you can imagine, the thymus is right there in the mediastinum. And with the proliferation of cells in the thymus, you can often see this. And this is just a dramatic example of the widening of that mediastinum that you can see on a chest X-ray. And this is what we're looking for when we ask the primary care docs to help us get the chest X-ray. And then you'll see on the CT here this squished little trachea. And that's what causes patients to feel short of breath when they're laying flat. And sometimes they'll cause some facial swelling or cough. So these patients we watch super closely. We avoid sedating them as much as possible. We know that, yes, they need to have lines placed, they need to have bone marrow tests, but we do everything we can to, while keeping them as comfortable as possible, minimize sedation, because when that happens, the airways can collapse, and with the pressure of the mediastinum, or this mass on the airway, can collapse the airway and lead to devastating complications. So we do everything we can. We try to do real minimal sedation for these patients when we can. So how do we treat leukemia? There's been a whirlwind of research and cooperative groups really trying to understand how best to take care of kids with leukemia. So it's been a combination of cooperative groups that are running clinical trials, multi-agent, or lots of different drugs are being used in one treatment plan to treat the leukemia. We have really fine-tuned risk stratification to understand which patients need more chemo and which patients may not need as much. There is response adaptation, meaning we look and see how patients have responded to the treatment to determine if they need more or if they need less. And then different modalities of treatment. So I just want to pause and kind of recognize the improvements that have come over the last probably 7 or 8 decades of treating childhood cancer. And just to orient everybody, this is a Kaplan-Meier curve. And if you look on this axis here, this is survival in percentage. So the percentage of patients that are surviving. And this is over the years since they were diagnosed with their cancer. And then this very first line is in the 1950s, before anybody knew what to do with leukemia. Basically, all children who were diagnosed with this died. In the 1960s, people started treating with multi-agent chemotherapy for short times, and people started surviving, but not for very long. They would almost all have relapses and come back. In the 1970s, this is when the introduction of central nervous system prophylaxis, and this was in the form of cranial radiation, which, as you can imagine, comes with a lot of side effects, negative side effects. However, what they found was this: when they started treating the central nervous system, kids started surviving longer term. which was great, but then we had to deal with the consequences from the radiation. In the 70s, people started using different combinations of chemotherapy and multiple cycles of chemotherapy, and kids started doing better. And then we added something called maintenance treatment, which in addition to the cycles at the beginning, we give them a long duration, multiple years of treatment to try to keep the leukemia away. Kids did better with that. Oops. Then therapy was intensified in the 80s. Kids did even better. Then we started figuring out how to risk stratify kids, meaning picking characteristics that needed more intensive treatment and characteristics that needed less intensive treatment. And kids did better. And then in the early 2000s, we got even better at this with looking at responsive, something called minimal residual disease that told us how kids responded to treatment that helped us better adapt. So this is just a little, I guess, picture of some of the different cooperative groups that we partner with. And the Children's Oncology Group is the main one that we work with. And this is an organization of over 200 institutions, mostly in North America, whose sole purpose is to learn as much as possible about how better to take care of kids with cancer. And the reason we have to participate in all of this cooperative research is because it is so rare. And with each individual institution doing their own clinical trials, we wouldn't have enough patients to learn about what treatments are effective without combining our efforts. And so this is a way for everybody to pool their efforts together and their patients together to really be able to power clinical trials to understand what's going to work best for kids. Multi-agent chemotherapy. So one of the principles of treatment is that we can't just use one medication. We've learned that you have to use all kinds of different medicines that work in different ways at different doses and different combinations and different schedules. And so you'll see patients have multiple different phases of treatment. Each phase is different from the last phase, and they all have different combinations, mostly of these medications. And then we talked a little bit about risk stratification. These are some of the factors that play a role in the risk stratification. That includes age. So kids that are infants, so babies, and kids that are over 10 have higher risk of their leukemia relapsing. Children that present with high white blood cells when they're diagnosed have a higher risk of relapsing. There are certain genetic features that are unique to the leukemia that can make someone's leukemia harder or easier to treat. And some of them are listed here. And then involvement, like in the central nervous system, can also make their leukemia harder to treat. And then this is a graphic of how we think about response adaptive therapy. And so if you think about leukemia as your lawn with roots underneath the ground that you can't see, we think about the first month of treatment as sort of that lawnmower effect, where you're trying to just get like the bulk of the disease away. Most of what you can see is going to go away. And after that kind of lawn mowing, you're left with potentially something that we call minimal residual disease, or MRD. And patients that don't have much of this minimal residual disease, we think that they may be easier to treat. And unfortunately, we think that even though we can't see any of the grass anymore, there's probably still some roots there that we can't see, because we know if we stop treating it, it'll almost certainly come back. So those patients will continue on with therapy and ultimately and hopefully achieve a cure. Patients that don't have negative MRD, we think that there may be a little of that grass still, plus all those roots that are still left behind. And those patients may benefit from more intensive chemotherapy in order to achieve the same chance for cure. So that's just an example of how we use kind of response to their treatment to determine how much treatment they might need. And then you all probably have heard about all the different modalities that cancer treatment can take, and this is true of any kind of cancer in adults or kids, but it can include surgery or radiation or chemotherapy. And generally, the approach for childhood leukemia is mostly chemotherapy, maybe sometimes a little bit of radiation, but generally not surgery for leukemia. Now, there are more and more molecularly targeted therapies that are coming into play, and then also immunotherapy agents that are coming into play. And our hope is that over time, in the near future, we're going to start to see a shift in the paradigm of how we treat childhood cancer, and hopefully be starting to move away from chemotherapy towards some of these more targeted therapies that will hopefully have fewer toxicities long term. So this is just a schematic of what ALL treatment looks like for patients. You'll see the first chunk of it here are sort of medium or higher doses of chemotherapy for the first 6 or 8 months of treatment, followed by a longer low-dose chemotherapy for maintenance. And these patients are usually going back to school and feeling quite good during this maintenance chunk of treatment. And then AML is quite different in that they have much more intensive therapy, but it's shorter. So this usually lasts about 6 months for patients, 6 to 9 months or so, and is mostly given in the hospital, whereas ALL therapy is mostly given outpatient. Some of these patients will proceed to transplant or hematopoietic stem cell transplant. And those patients that go to transplant, this is used for curative intent, and we usually only recommend this for patients with the highest risk disease. But as you can imagine, with higher intensity disease, that comes with higher toxicity. And the thought with hematopoietic stem cell transplant is that there are 2 kind of mechanisms in which it can help someone overcome their leukemia. And one, it allows us to deliver very high doses of chemotherapy to patients that may have become chemotherapy resistant, and that they then are rescued with stem cell infusions. And then also the stem cells themselves, you're giving someone a new immune system, and that new immune system with its own sort of tumor surveillance can cause what we call graft versus leukemia, where those immune system cells can target the patient's any residual leukemia that's there. But the flip side of that is that they can have complications with graft versus host disease. So supportive care is really important in what we do and how we take care of our patients. And we do a lot of work on trying to reduce the risk of infections. And many of our patients will require prophylaxis to help protect them. And that can include pneumocystis prophylaxis and bacterial and fungal prophylaxis for some populations. We do a lot in supporting patients with nausea and pain. We do avoid vaccines during treatment or routine childhood vaccines, partly because patients won't respond to them. They don't have a robust immune system response to be effective. We do, however, encourage influenza and COVID vaccines during therapy for everybody. Fever, we treat as a medical emergency in all of our patients, and these patients are being seen quickly and have antibiotics started quite quickly. And then transfusions are another important part of supportive care. Kids that have their leukemia come back, this continues to be a challenge. These patients often don't have the same great prognosis that they did when they were first diagnosed. The patients that had B-cell leukemias have the most options, and many of them still do well, even if they have relapses of their disease. Some of them require more chemotherapy. Some of them are receiving immunotherapy or agents like CAR T cells, or some are requiring transplant. Patients with AML that relapse almost always require a transplant for a chance of long-term cure. But I think what's important is that molecular and immunotherapy type treatments are really changing the landscape of how we take care of these patients. There are just so many more options for patients with all leukemias, but most specifically ALL patients if they do relapse, which is a reason to be optimistic. And this is just an illustration of some of that molecular targeted medications that can really change outcomes for patients. So this is just the example of imatinib or Gleevec that you probably heard of that came out a long time ago. And this targets patients that have BCR-ABL leukemias, the Philadelphia chromosome. And children can have the Philadelphia chromosome, sometimes in ALL. And those patients traditionally had a really dismal prognosis and did really poorly. You can see prior to the release of imatinib, these patients had about a 20% or 30% long-term survival chance. And the clinical trial that incorporated imatinib into the treatment backbone, you can see in in 2009, this was published, they jumped from about 20 to 25% survival to 80% survival with one study. And the only thing that was changed was adding imatinib, which is really pretty inspiring. So immunotherapy is really the wave of the future, and I think where we all are hoping treatments are going for hope all of our cancers at some point. Rituximab is one of the older ones that we've been using for a long time that targets something on the outside of lymphocytes. Inotuzumab is something called an antibody drug conjugate, which basically is a monoclonal antibody that's attached to a cytotoxic drug, and it's a delivery agent. It targets something on the outside of the cells and then plants that toxic drug there to do its job. And then we have something called bispecific antibodies that target both something on the tumor cells and then also target something on our own T cells. So the example of this one that I use is blinatumomab. It targets CD19 on tumor cells, but then also engages our own healthy T cells to come to the tumor cell and kill it, which is pretty cool. And then CAR T cells, which are chimeric antigen T cells or receptor T cells, otherwise known commercially as Kymriah. And you may have heard of some patients going to receive this therapy, but essentially it is taking the patient's T cells, apheresing them out of their body, sending them to the lab to be engineered to target something on the outside of their leukemia cells, usually CD19, and then infusing it back into the body to harness your own immune system to kill the cancer. And we've seen really phenomenal results with this. So I think this is just an example of, patients are failing their upfront chemotherapy. These are the types of things that we're starting to add as patients are relapsing. And I think just to be something very exciting is recently a clinical trial is releasing some early results that blinatumomab, when used in patients getting treatment for the first time, so newly diagnosed patients with ALL, we now know can benefit from blinatumomab at the beginning. And I hope that that's the first step of us starting to incorporate some of these sort of lesser toxic agents early in treatment, and at some point being able to pull away some of those toxic things that patients are exposed to. So we're hoping that this is where the future of cancer treatments is going. I think importantly for your group, what are the effects of treatment and what happens when they're done with their treatment? And I think, one thing to really emphasize is that it's so important for patients as they're finishing their cancer journey that they become reintegrated with your team. It's so important. And so we encourage that as early as possible. As soon as treatment is complete, we're encouraging them to reestablish care so we can communicate with you, send you records, make sure that you have what you need. We will continue to follow the patients in parallel with you. We're watching them for relapses of their disease. We're watching for late effects of their treatment. And we're, helping you all if you have questions as you proceed with all their routine health maintenance and any sort of non-oncologic related issues that happen. So, some of that involves catching up on vaccinations that we usually recommend starts at the 6-month off therapy point. We wait till 6 months off therapy, not so much because we think they're dangerous, but because we want to wait until the patient's immune system is reconstituted enough to have a robust response to them. Otherwise, we worry giving them at 2 months or 3 months, they might not respond and it may not be worthwhile. And so we encourage you to look, if you have patients in that scenario, we often guide you to the CDC catch-up immunization schedule as a guide for sort of when kids need which vaccines. Patients going through routine leukemia treatment don't need to be entirely revaccinated. They just need to catch up on what they've missed. And so we really want to partner with you all to really help set up our patients for success as they finish their treatment. And again, late effects are really the big, huge downside of cancer treatment. And as we are curing more and more of these patients, more and more of them are getting to adulthood, and which is a great thing, but we're seeing more and more of these late effects as childhood cancer survivors are increasing. And each disease and each different regimen that we give have different kinds of late effects, and so it really is important to know what your patients have received, therefore really understanding what late effects they've been exposed to. And I think just to highlight for leukemia specifically, this is sort of a list of some of the common things that we think the medications that we use can impact. And one of those things is fertility. And we have an onco-fertility team that we try to have meet with all of our patients before to talk about what fertility preservation options might be available for them. Cardiotoxicity with anthracycline exposure. Many of our patients will have obesity and metabolic implications down the road. After intrathecal chemotherapy repeatedly, some patients can experience some neurocognitive effects, specifically like with executive functioning, for example. And so we encourage those patients to have neurocognitive testing. Bone health, so patients can be at higher risk for decreased bone density and fractures. Some patients can unfortunately experience secondary cancers that are a result of the treatment that they received, which is always devastating. And then, the obvious psychosocial impacts of treatment, as well as dental decay and dental health problems. So I just wanted to point you to this resource that's publicly available. This is the survivorship guidelines that are published by the Children's Oncology Group, that research organization that I mentioned earlier. And this is really just a guidebook. You can go through it and look at the drugs that your patients have received, and then it gives you very specific action items or surveillance items that need to be done. We're going to be following this in their kind of post-cancer care. They're going to continue to see their oncologist usually for about 2 years following their treatment. And then when that 2 years is up, we don't just say goodbye. We help incorporate them into our survivorship programs. And the goal of the survivorship programs is for them to have a connection to providers that are familiar with these long-term follow-up guidelines, so that they can really make sure they're aware of what risks they have as they get older, and what screening and surveillance tools need to happen based on what treatments they've received. When patients become adult age, we help them transition from our pediatric survivorship program to an adult program, usually if they're going to stay here at University of Washington. And that's really it. I think, the goal is for, folks to recognize that leukemia is the most common cancer that we take care of in kids, and that most kids are cured with modern therapy and how we risk adapt our therapy, but that relapses are really problematic still. But that in our era of molecular and targeted therapies, I think that there's a whole lot more optimism than there used to be. And then I think specifically late effects of treatment are something that's important for you all to be aware of as you see them in your clinics. And I think I left a little bit of time for questions.
Awesome. Thank you so much, Amy. I know we have one question in the chat. Just as a reminder to everyone before we get to that, if you do have questions, feel free to put them in the chat. You can also raise your hand. There's an icon at the bottom of your screen. If you press that, we can go ahead and unmute you if you want to ask your question virtually. And then if you do have to hop soon, I did put a link to the evaluation in the chat if you wouldn't mind filling that out. So this question, and as a friendly reminder to everyone, I am not clinical, so I will do my best to pronounce these words. From Farnaz, you mentioned that we don't treat hypocalcemia until we have to. Does the same apply to hypomagnesemia?
Oh, good question. No. So, most of the time we aren't even like watching magnesium for tumor lysis. It's not something that we typically see, but there doesn't seem to be the same risk associated with supplementing magnesium. In fact, if you are worried about cardiac function, that's something that would be important to to supplement.
Great, thank you. From Rebecca Lynn, this is a very specific, so I don't know if you'll have the answer. The UW Environmental Peds team was going to look into the increased incidence of leukemia in Yakima County, which was 4.75% compared to 0.8% statewide. Have you guys heard anything about this?
That's a great question. The answer is I haven't heard any formal feedback about it, but I share your experience and just from observation or anecdotal experience, that seems to be an accurate statistic. But that's a great question and something I can try to follow up on.
Thank you. Next question, excellent talk, thank you. My question is, if the patient presents with, goodness, lymphaden.
I'm looking at him now. I can see him.
Okay, great. You can read that.
If a patient has presents with lymphadenopathy, normal CBC, how do we rule out lymphoma? Is biopsy best? So the answer is biopsy is the only way to diagnose lymphoma, but it's not always necessary. And so that's, I think, in a situation where kind of looking at that algorithm and kind of thinking through what those kind of red flag things are and reaching out and talking to us. So we're always happy to see a patient, but really the only way to know for sure if a patient has lymphoma is to biopsy it. And patients with lymphoma don't always have abnormal CBCs, as you know. So, you know, a lot of it really depends on the characteristics of the lymph nodes themselves. Is it a lymph node that's over 2 centimeters? Is it firm? Is it mobile? There are a lot of different kind of characteristics of the exam that can be helpful. But we see a lot of lymphadenopathy referrals for patients that have had lymph nodes for a long time that don't feel pathologic on exam. So I think that's where, you know, a conversation can be super helpful, is just understanding the characteristics and determining whether or not a biopsy is indicated. And sometimes we don't know, and we observe for a while and see what happens to the lymph nodes. And if they stay the same or get better, we oftentimes don't. And if they are getting bigger, we will biopsy them. So that's not a very straightforward question or a straightforward answer to a pretty seemingly simple question. But the answer is biopsy is the only way to know, but we don't always think it's necessary.
All right, thanks, Amy. And we will send out that algorithm with the follow-up materials so everyone has access to that too. In case you're not familiar, we do have a healthcare professional site on seattlechildrens.org with 60 plus algorithms and sort of clinical care resources. So that's included, but we'll send this specific one out with follow-up materials. All right, looks like that is everything in the chat. Final check-in before we wish you all a good afternoon if anyone has any additional questions. Alrighty, I think we're good. Well, thank you all so much for joining us on your lunch breaks. I know you all probably have busy clinical practices to get out back to. So thanks again for spending time with us, and we will see you next time.
Thanks, everybody.
Thank you.